Hi everybody, we're just waiting for everybody to get online, so just bear with us whilst everybody's joining. The numbers are going up, which is great. Okay, looks like we've got most people on now. So thank you very much for joining us today. I am Joanna Travis-Roberts, the Chief Executive of ISSUP, the International Society of Substance Use Professionals. We have put this webinar together today in partnership with ISSUP India, who are our national chapter in India, who co-organised this event for us, have just put the panel together and have played a really significant part in bringing this subject to you today. We're unfortunately very saddened that none of our colleagues and friends have been able to join us today from ISSUP India. As you're all aware, the situation in India with the coronavirus is severe at the moment, so they are all working on that, and we really are sending them and everybody who is in India our best wishes and positive thoughts during this difficult time. So first of all, I'll tell you a little bit about ISSUP. We're an international membership organisation that are really focused on the development, support and representation of a professional workforce in substance use prevention, treatment and recovery. We're delighted we've got 18,500 members around the world. We're supported by the US State Department through their INL office and enjoy excellent working relationships with all of the international organisations and partners who all sort of bring their services, their expertise, and we then sort of share that with our network, our ISSUP members. So we sort of like to connect rather than generate a lot of content. We're putting people in touch with the right people and places. The vision of ISSUP is a connected, trained, knowledgeable and effective international network of substance use prevention, treatment and recovery professionals who are undertaking and promoting high quality, evidence-based and ethical substance use prevention, treatment and recovery. And I just want to always sort of reinforce that when we think about this network, when we're thinking about the ISSUP membership, we really are including all elements of the substance use workforce, from volunteers, family members, to those of you who've made it a lifetime academic study, or it's, you know, the major focus of your professional work. But every piece of that puzzle is really valuable in our joint efforts. We undertake our work three ways. So we have a digital channel, which is obviously our website, our online events such as this. We have regular in-person events which are now taking place a lot more online, like these regular webinars, but also we still plan large-scale conferences when in-person allows it. And our national chapters, as I mentioned, such as ISSUP India, that allow us to work with key organisations at a country level to connect with members within their own language, their own culture, their own reference points. And we have currently got 24 of those around the world. So on to today's topic. I think, you know, most of you will be aware, but just to give a brief background, that globally there are 942 million men and 175 million women aged 15 or older who are current smokers. Tobacco kills up to half of its users. More than 8 million people each year, the numbers from WHO show us. Male smoking prevalence is highest in the Asian region, with over 400 million daily smokers living in China, just for example. So I think we all know the seriousness of this subject, but it's the first time we're sort of focusing on this in a webinar series like this. So we're delighted to bring this panel today, but also, you know, subsequent panels over 3 webinars to acquaint you with all the aspects of tobacco use, prevention and addiction treatment approaches. We really want to raise awareness on the issues around smoking, nicotine, the different types and substances that are used, with a view to helping young people especially, and to really highlight that smoking and all forms of tobacco use remain major public health issues. Some housekeeping for today's webinar. It is being recorded, so if you've joined and you lose us, or if anybody who's registered can go back and watch the recording, and it will be on the ISSUP website in a couple of days. Everybody who participates will get a certificate of participation, and we're going to hear from our 4 panelists. If you have any questions, please pop them in the questions box, which you can all see, and we will gather those together. We'll do a Q&A session for all 4 speakers at the end. As always with these online events, bear with us if we have any technical difficulties. We'll be ironing them out in the background. I think we're all rather used to them happening now, but I'm sure that it will be a very successful event. So thank you to our speakers. We're going to move over to our first speaker today, who is Dr. Pratima Murthy. She is Professor of Psychiatry and Head of the Department of National Institute of Mental Health and Neurosciences in Bangalore. She's a Fellow of the Royal College of Physicians and Surgeons in Glasgow and a consultant to several international agencies such as United Nations Office on Drugs and Crime, the International Labour Market and the World Health Organization. She's an international trainer for tobacco cessation training and a training of trainers as well. She's authored manuals for tobacco cessation for doctors, dentists and nurses, as well as community health workers for WHO, and is involved in developing the national guidelines for tobacco cessation in India. Oh, sorry, I didn't mention as well that she's the lead author of the standard treatment guidelines for substance use disorders and addictions for the Ministry of Health and Family Welfare for the Government of India. So an extremely experienced and knowledgeable speaker that we'll be hearing from first. Thank you very much, Dr. Murthy, for joining us today.
Thank you very much, Joanna. It's a pleasure to interact with all of you today. I'm just going to see if I can get my screen working. Just give me a moment. Olivia, can I just request you to kind of start my presentation? I think I seem to be. Olivia, can I just request you to start my presentation from your end, please? Thank you. I'd just like to request all of you to hold on for a second till we get the presentation started. Thank you very much. So my talk is titled Meet Your Poison, and I'm going to try and introduce you to tobacco use and nicotine addiction. As Joanna mentioned, I've had several decades of work in this area, and I think there's a lot that we need to look at and do in terms of trying to address this problem of tobacco use. Can I have the next slide, please? I don't have any conflict of interest to declare. The next slide. So what I'm going to do today is really address the 2 whats and the 4 whys of tobacco use. We'll see what tobacco is, and I'm sure, many of you know more than I what tobacco consists of. But the most important question as to why people use tobacco. Why is tobacco a drug, and why do we have to deal with it like other drugs of addiction? What is the global extent of tobacco use? And what kind of a problem does it face? Do we need to face? The specific problems with tobacco use in terms of mortality and health risks, specific focus on tobacco and cancer, tobacco and non-communicable diseases, and as Joanna mentioned, during the COVID pandemic, the relevance of tobacco use and the risk that it poses. We look at tobacco use and addiction, and also focus on why quitting is important at any stage. Obviously, it's best not to start tobacco use, but it's also very important to quit tobacco. The next slide, please. So talking about what tobacco constitutes, it's obviously derived from the tobacco plant leaf and its products. And if any of you have seen the cultivation of tobacco, it's a very attractive leafy a plant from which tobacco is derived. And there are 70 species of tobacco that is known. But the chief commercial crop, and that is a huge cash crop, and that's the tobacco genus. And the more potent variant, the rustica, is also used in some countries, but it's predominantly the Nicotina tabacum. And it is a poison because it contains about 7,000 chemicals, including 70 cancer-producing substances. In the next slide, we'll actually see what the constituents, what the different forms of tobacco are. And in different countries, you have different forms of tobacco use. All of us are very familiar with the smoking forms of tobacco, and we mostly know about cigarettes and cigars. But in many countries, particularly in South Asia, one of the most common ways of smoking tobacco is through bidis and kritex, and of course in Indonesia. We have the smokeless forms of tobacco as well, and we have in other things like the hookah or the nargil, where you bubble the tobacco and kind of inhale it. The betel quid is another smokeless form of tobacco that is very common in South Asia. So you have a huge variety, and that's really one of the challenges, because tobacco comes in so many different forms and use. And of course, in some countries, it is also used as snuff. The next slide, please. Particularly in South Asia, the smokeless forms of tobacco are very common. And in India, for example, there are a variety of smokeless forms of tobacco. And Joanna mentioned that smoking is more common among men than in women. But when you look at smokeless tobacco, a huge number of women also use smokeless tobacco. And men use both smoking as well as smokeless forms of tobacco. And there are a variety of things. And as you saw in the previous picture, it is very often combined with the betel quid. Tobacco is combined with the betel quid and kept in the mouth for long periods of time. It also, is there that in some parts of the country, you also have people gargling their mouth with tobacco dentifrices, which people use to brush their teeth early in the morning. So a huge variety of tobacco that is available in different parts of the world. The next slide, please. So, in terms of the various kinds of chemicals and poisons that are available in tobacco, or that that this is a cigarette, and mind you, cigarettes are possibly slightly, there are worse forms of tobacco that are taken, but in the cigarettes itself, you'll find that there are so many chemicals that are particularly toxic. You'll find the same kind of fluid that is there in lighter fluids, the cadmium that's there in batteries, stearic acid that's there in candle wax, carbon monoxide, methanol, methane or sewer gas, arsenic. So there are ammonia. There are a variety of chemicals that are present in tobacco, and we really don't think of the kind of toxins that we're inhaling. And that's why I think, while somebody said, while an author said that a cigarette might be the perfect form of perfect pleasure, another person said it's fire at one end and fuel at the other. So I think it's very important to really understand the way tobacco can actually affect us because of the kind of toxins it contains. The next slide, please. But the most important question is, why do people use tobacco? And I think it's very important for us as professionals to really understand the personal reasons as to why people use tobacco. So as I mentioned the author earlier, it is for enjoyment because people feel that it's the easiest way to kind of feel relaxed, feel calm, feel good. To ease boredom. There are a lot of young people who don't know what to do and kind of smoke or chew tobacco to ease boredom. A lot of people believe that at the end of a long day, the only way to relax is to either smoke or chew tobacco. Tobacco is perceived to have mood relieving properties, and that's why many people who are dysphoric or feeling low try to improve their mood with tobacco use. And finally, of course, they have to use it because it becomes a habit. And we'll talk about the addiction for tobacco a little later. And once the person becomes addicted, several physiological functions then become dependent or contingent on tobacco use, particularly a bowel movement early in the morning. So to relieve constipation and to relieve the withdrawal symptoms, people continue to use tobacco. So this is at a personal level. When we look at it at a larger public health level, in the next slide, we'll actually see that tobacco use is linked to a variety of factors. The next slide, please. So let's start off with the nicotine that it contains. One of the main reasons why people use tobacco is because of the psychoactive properties of nicotine. It also serves as a social reward because you feel that you're in a company of people who are smoking, and therefore you feel part of the group. Family influences. Now, family influences work both through modeling within the family. So a lot of young people, for example, might see an adult in the family smoking, particularly with smokeless tobacco. There are older women in the house who are chewing tobacco, and then the person learns to chew tobacco. As I said, the stress and self-medication is another reason. In families, apart from modeling, we know very, very well now that nicotine addiction is something that is both determined genetically as well as environmentally. So it's a genetics into environment interaction that leads to maintains a tobacco habit. And we also know that availability, accessibility, and media influence can also encourage the use of tobacco. Very often tobacco in one hand and there's a drink in the other. So alcohol and tobacco may also go hand in hand. The next slide, please. So what are the common factors associated with any kind of substance use? And particularly in the ISSUP, I think it's very important to really connect up tobacco and other drugs as well. So the three A's, the availability, accessibility, and the acceptability of substance use in a particular community or environment, influence from peers, influence from popular media, the social acceptedness of the habit, temperament and coping skills. These are individual factors. So in addition to genetic risks, certain types of people who find it very difficult to stay still, find it difficult to focus attention, who want immediate gratification, or people who are extremely anxious, these kind of temperaments may be at greater risk to use tobacco. And of course, in addition to the genetic risk, the family modeling as well. So it's very often like the layers of an onion, that you have multiple risk factors which kind of promote and maintain the habit of tobacco use. The next slide, please. So why is tobacco a drug? It's a drug because it acts on the brain. It's a psychoactive substance, and nicotine is the psychoactive constituent of tobacco. And as you see in this picture, it actually acts on the reward pathways of the brain, the same areas where alcohol, cocaine, and heroin act. And these are areas which are triggered when there is any kind of pleasurable activity, including food when a person is hungry, water when they're thirsty, sex, etc. And therefore, this pathway is activated, and all of us know that dopamine is released, and that's pleasure giving. But what usually happens is, as all of us know, the repetitive use, there is what is called tolerance that develops. The person needs to use more and more of the same substance to get the high, and that leads to a vicious cycle of addiction. The next slide, please. In the next slide, you'll see that when you compare the likelihood of dependence, actually tobacco is possibly more dependent than many of the other illicit drugs, because in terms of the availability, etc., there is a higher likelihood of people who use tobacco becoming dependent on the tobacco as compared to other drugs. Next slide, please. So there is no other psychoactive substance that affects the brain chemistry as much as nicotine. And that's why when a person becomes addicted to it, it might be one of the most difficult things that the person does to be able to give up tobacco use. And that's why I think empathy and understanding is very important when dealing with people who have any form of addiction, including tobacco addiction. The next slide, please. So why is tobacco a global problem? As you see here, this is just the percentage of adult males who smoke daily. There are countries where almost more than 50 to 60% of males are tobacco users. And you'll find that a majority of them are daily users. And therefore, once there is daily and regular use, you can expect that a large number of them would be, at least a third of them would be addicted. And therefore, in many countries, there has been a reduction, and that's occurred because of huge public awareness, laws against tobacco. We'll look at that a little bit later. But in many of the developing countries, there are high rates of smoking all over the world. The next slide, please. And As Joanna mentioned, it's possibly the only legal consumer product that actually kills up to half of people who use it as it's intended. And by 2030, it's estimated that there will be more deaths from tobacco than the total deaths from malaria, maternal conditions, and injuries combined. So unless we take very, very prompt action, we will see a huge amount of mortality and morbidity due to tobacco use. The next slide, please. So we all know that there are a huge number of problems that are associated with tobacco use. In terms of deaths, 8 million people die each year. And while a large number of these are directly related to the use of tobacco, a significant proportion of them are also because of exposure to secondhand smoking. So one important thing about smoking is that it's not only harmful to the user, but also to the people around them because of the secondhand or passive smoking. And the other very, very sobering fact is that 80% of the 1.3 billion tobacco users live in low and middle income countries where access to health may not be as good, and they don't get to help adequately, and tobacco cessation services aren't very, very well developed in these countries. So as you see in the picture, right from early cataract to loss of hair to much more severe problems, including cancers, of course, neurological conditions, cardiovascular conditions, respiratory conditions, the gastrointestinal system being affected. There is no part of the body that is spared from the effects of tobacco use. So I think it's very, very important for all of us to understand that tobacco is extremely toxic to every single part of the body. Next slide, please. One of the things that young people need to know is that tobacco can actually cause sexual dysfunction in the form of erectile dysfunction. A lot of young people smoke to maintain an image, and they need to understand that it actually, causes a huge amount of things, and these occur early. So there are lots of early, I think the messaging that we were conventionally giving is that tobacco produces cancer or, chronic disease, but that's something that occurs several years away. But there are much more proximal effects of tobacco use that young people need to understand, including premature aging and erectile dysfunction. The next slide, please. The most important thing about oral tobacco use, again, is that is the production of cancers, and both smoking as well as smokeless forms of tobacco are associated with a variety of cancers, starting from oral cancers to the GI system, to lung cancers, to leukemias, and even to urinary bladder cancers. So I think it's very important to really look at, when you look at the preventive risk for cancer, tobacco stands out as a very, very prominent behavioral risk which can be modified and reduce the risk of cancer. The next slide, please. So in the current context, COVID is the current, we're having seen different waves of the COVID pandemic, and we know now that tobacco use is a huge risk factor, both to acquire COVID infection and also recovery from COVID and having complications from COVID. So I think now is a huge opportunity for people who are using tobacco to quit, because they can actually improve outcomes from COVID should they get infected, and of course even reduce their risk from COVID. And I think that's a message that we need to put forth. We're encouraging through the quit lines to tell people to come forward and take help if they have a difficulty giving up tobacco on their own. Next slide, please. Tobacco is also a risk factor for non-communicable diseases like diabetes, cardiovascular diseases, cancers, strokes, and common mental disorders. And tobacco rarely occurs alone. As you know, tobacco and alcohol very often go hand in hand, as does stress, as does poor diet and physical inactivity. So when you look at it all together, this forms a huge nidus or a preventable risk factor for a variety of these diseases. And it says that genes load the gun, it's lifestyle that pulls the trigger. So there is a lot of lifestyle related modifications that we can do to reduce our risk and outcome from non-communicable diseases. And therefore, looking at tobacco cessation is a very, very important way of reducing risks for non-communicable disorders. Next slide, please. This is an integrated model of how tobacco and stress go hand in hand. You'll see that people who are stressed use tobacco. We can keep going to the next slide because it tells us the relationship between tobacco, stress, violence, alcohol and drug use, as well as HIV/AIDS. So it's very important to look at the interrelationship and not look at tobacco as a problem in itself. It is related to a whole lot of other problems, and it's important to look at it in an integrated fashion. The next slide, please. The other important issue is secondhand exposure or secondhand smoking, and particularly in developing countries, we know that several pregnant women are exposed to secondhand smoking at home. People, almost 3 in 10 adults working indoors are exposed to tobacco smoking in workplaces. Even in public places, for example, people may be exposed to tobacco smoking. And of course, we know that in many small-scale industries where tobacco is produced, particularly the beedi industry, there are a lot of women who also work in these industries and are exposed to green tobacco sickness and other forms of diseases, including anemia, because they work in these areas. So tobacco, again, has a lot of consequences, much more than just the person who is using the tobacco. Next slide, please. So why is quitting important? In the latter part of my presentation, I'll talk about the benefits of quitting. And we know that there are benefits which start accruing as early as 20 minutes after one stops tobacco use, where the blood pressure and the pulse rate comes to normal. Gradually, what happens is that the oxygenation improves, the carbon monoxide levels drop. By about as early as 24 hours, the risk for a heart attack can reduce. In a couple of days, the ability to smell and taste improves. In a couple of months, the blood circulation improves, the lung function improves as much as 30% in just a matter of 3 months after stopping tobacco use. There are a lot of immediate gains by stopping tobacco use. Next slide, please. And these gains continue to persist for many years after stopping tobacco. In terms of the respiratory problems improving, in terms of the risk of coronary disease, risk reducing by about a year, the risk of stroke reducing by about 5 years, the risk of dying from lung cancer being reduced by half 10 years. It takes a long time to reduce the cancer risk, but nevertheless, if a person stops quickly, they can neutralize the risk from cancer. And of course, at the end of 15 years, the risks kind of become as much as the normal population. So there are immediate gains from tobacco use. There are also long-term gains from tobacco cessation that people need to know about. The next slide, please. But although we know that there are benefits from quitting, it's not very easy to quit once a person is dependent on tobacco. And that's because of the withdrawal symptom it causes. It causes irritability, insomnia, anxiety, appetite disturbances, and restlessness. But it's very important to understand that these last for a few hours to a few days. And if the person is well equipped to handle these things, the person can overcome the withdrawal. Craving is something that can persist for several months, and the person also needs to understand how to deal with the craving to be able to give up tobacco. I'll conclude in the next couple of minutes. The next slide, please. So the principles of intervention are akin to a traffic light. The idea is to keep the greens green. People who are not using tobacco, make sure that they're tobacco free. People who are using tobacco, make sure you improve their awareness and get them motivated to stop tobacco. And of course, for people who are addicted to tobacco, you need to give them more intensive care and support to help them to quit tobacco. The next slide, please. A variety of approaches for tobacco cessation have emerged all over the world, and they've been very effective in helping people quit. From quit lines to mobile cessation programs, to online support programs, to apps for tobacco use, to psychosocial interventions, as well as pharmacological interventions. There's an array of interventions that are available for people to encourage them to quit tobacco use. Next slide, please. The Empower approach, which is from the WHO, looks to monitor tobacco use and prevention policies, protect people from tobacco smoking, offer help to quit, warn people about the dangers of tobacco, enforce bans on tobacco advertising and promotion and sponsorship, and raise taxes on tobacco. The offering of help to quit tobacco and warning people about the dangers of tobacco lie with many of us who work in the health sector, so it's very important. I'd like to leave you with the message that tobacco is a poison. It's very important for people to know about this poison. It's obviously best not to start tobacco at all, but it's also very important to quit as early as possible. And for people who are addicted to tobacco, they need an empathetic understanding and support to quit tobacco. A wide variety of interventions are now available, and all over the world, with increasing awareness, more people are stopping tobacco and not starting tobacco. And we need to make sure that the world is a healthier place by providing messages about the dangers of tobacco use. Thank you very much. Joanna, I think you're muted.
Well, good morning and afternoon. Are you all able to hear me? I want to make sure that that's coming through. Someone can put in the chat. Okay, wonderful. I will take that as my cue to start. I am Nick Fradkin. I'm the tobacco treatment consultant here at the Washington State Department of Health in the US. Yeah, thanks so much to ISSUP for inviting me to speak on this important topic. And I am assuming that you can see my slides. Okay, I will keep an eye on the chat just in case to make sure. Yeah, so based on my presentation title, you might expect me to be speaking about tobacco dependence treatment, but instead I'll really be talking about the imperative, similar to Dr. Pratima Murthy, who did an amazing presentation. And I will do my best to match the quality with that, despite my lack of medical or doctor credential by my name. Let's see. So, and time permitting, I may share some information that might serve as a sort of preview for future webinars. But yeah, here's my information. I am again, tobacco treatment consultant at the Washington State Department of Health, Washington, the state, as opposed to our nation's capital in the District of Columbia. So yes, I have nothing to disclose aside from the fact that I am a government employee, and I'm doing this talk on my own time. It's about 6:30 in the morning over here and wouldn't want to be anywhere else. So here's a brief overview of what I'll be sharing today. For the theme of today's talk, tobacco use, pleasure or harm, I'll be sharing a short list of the pleasures of cigarette smoking, and then necessarily spend a lot more time on the many harms of smoking, both to individual health and our ever global society. I'll then share some basic information about smoking cessation and associated risk reductions. I should note now that I will not be addressing electronic nicotine delivery systems or e-cigarettes. And for that, I'm thankful because it's a very complex topic that I understand is being covered later in this series. And I'm just seeing the chat. I assume you're still able to hear me. Okay. So yes, and time permitting, I'll share some information about what our state and federal governments are doing about cigarette smoking and commercial tobacco more broadly. and end on a note about an important holiday at the end of this month. So, smoking, pleasure or harm? I will argue that it's both, but it's really not a close call as to what the right answer is, as I think Dr. Pratima Murthy implied. But to give pleasure its due, and I should also disclose that I myself have never smoked a cigarette, and I am very privileged to be able to say that. What I have learned, though, is that there are two main types of pleasures that people derive from smoking. Just to kind of simplify it a bit, and both of these are critical to consider in terms of smoking cessation. So first, physical pleasure, and as this audience surely knows, drugs make you feel good, at least in the short term. Never mind the long term, we'll get to that very quickly. Again, nicotine is a psychoactive drug. It is the psychoactive drug in cigarettes, each of which contains about 1 to 2 milligrams, depending on the brand. And nicotine gets delivered in a series of puffs, which delivers nicotine to the brain receptors, the receptors in the brain, in about 10 seconds. So a very quick and efficient delivery mechanism for a drug. What's interesting about nicotine is that it releases dopamine with short puffs, but tends to release more serotonin with long puffs. So it's to kind of go off Dr. Pratima Murthy's poison theme, it's kind of a picture poison kind of device. However you use it, you can kind of get a different effect. Of course, the problem here is that nicotine is extremely addictive. Some researchers estimate that it's as addictive as cocaine or even heroin, which really creates this second pleasure and reinforces behavioral changes that manifest in sort of a lifestyle change, one that's relatively socially acceptable, even here in the US. People who smoke often take breaks from work, often find themselves in social circles with each other, again, further reinforcing the smoking behavior. This is why it's so easy for people to get to the point of smoking a pack a day or more. And yes, co-use was covered in the previous presentation, as well as sort of the weight control and the the tendency to project an image of health or even sex appeal with cigarette smoking. And so that cigarette smoking is so pleasurable is precisely the reason why we need increased attention on the harms of tobacco and dependence treatment. That's all I'll say about the pleasures of cigarette smoking, and now on to the many harms of cigarette smoking. So while there was certainly research being done on smoking in the earlier part of the 20th century, we Americans didn't start taking smoking seriously until about the 60s, when the first Surgeon General's report linked smoking to lung cancer and other disease. That's the report on the left. Interestingly enough, the primary study cited in that report came out of the UK. It was the British doctor's study. And that study was actually used to develop scientific criteria for determining causality in observational studies. So in other words, the relationship between smoking and lung cancer, which I'll show on a future slide, is so abundantly clear that it warranted documentation of new scientific theory. So one could really argue that this was the beginning of social science as we know it. And fast forwarding to 2014, 50 years later, more than 20 million Americans alone have died because of smoking in that time. And almost currently 500,000 die each year. And we still call this progress. Yes, it could have been a whole lot worse. Our smoking rates have gone down from 40 some odd percent to about 14% in the US. Yeah, so it obviously could have been a whole lot better given the amount of death I mentioned. So the Surgeon General released several different reports between 1964 and 2014, but I want to highlight 2010, the How Tobacco Smoke Causes Disease. The previous presenter talked about the chemicals and compounds. I won't go into that, but there are hundreds of toxic chemicals, about 70 cause cancer. The chemicals and toxicants reach the lungs very quickly along with the nicotine to the brain, and the blood. How this works really is that the blood carries these toxicants to every organ. They end up damaging DNA, and that's what ends up causing cancer. These chemicals can also inflame cells or cause inflammation and damage cells and weaken the immune system, which is another reason why COVID-19 is such a concern these days vis-a-vis smoking. Interesting point, the tobacco industry has made some product improvements over time. I put that in quotation marks, like filters that actually don't work as advertised and cause people to inhale more deeply, for example, and end up compromising health. And another point here I'll say is that these risks balloon, or they can balloon. There's a dose-response relationship between smoking, how much someone smokes, how long, and how much risk they sort of accrue over time. All to say that there is no safe level of exposure to tobacco smoke. So here's a similar diagram from the previous presentation. This is from the 2014 Surgeon General's report. The key point here is smoking can damage every part of your body. We kind of continue to add to the list of specific cancers and conditions. Most recently, liver and colorectal cancer were added to the laundry list of now over a dozen cancers caused by smoking or exacerbated by smoking. Chronic diseases, even a longer list. I will go into that a bit more. But first, some attention towards cancer. What you're seeing on this slide is the relationship between cigarette consumption over time and lung cancer deaths in the US. So you'll see that there's about a 20-year lag. And so again, as I mentioned, yes, correlation doesn't equal causation, but based on other criteria, we can really infer that the tobacco industry all but invented lung cancer. It was very seldom diagnosed prior to the advent of the cigarette. And what's sad here is that the U.S. is a lot further along than other countries, and so we hope other countries can learn from our mistakes. Global burden has shifted, I will say. I think Dr. Pratima Murthy had a similar slide, but this is from the Global Burden of Disease study, actually here in Seattle at the Institute for Health Metrics and Evaluation. And so what this shows is that over the past 30 years, lung cancers attributable to tobacco have increased, mostly in China, Indonesia, and India. Those are the darker red colors there, while we've kind of been level in a lot of the Western countries. So chronic disease. I think I won't go into too much detail here, but smoking can cause lung disease by damaging airways and the small air sacs found in the lungs. COPD, chronic obstructive pulmonary disease, emphysema, pneumonia, tuberculosis, asthma, all caused or exacerbated by smoking. Makes it hard to breathe. And then, severe COVID-19 illness is on our CDC's list of possible outcomes from smoking. And I'll add for cardiovascular disease, we have the higher risk for stroke, coronary heart disease, which are among the leading causes of death in the US. And even people who smoke fewer than 5 cigarettes a day can have early signs of cardiovascular disease. Smoking damages blood vessels, can make them thicken and grow narrower. And of course, it'll make the heart beat faster, raise blood pressure, clots can form. Yes, smoking can increase the risk of coronary heart disease and stroke by 2 to 4 times. There are myriad other risks. Diabetes, it's a cause of diabetes, type 2 that is, and make it harder to control. Tooth, vision, hearing loss, also possible outcomes from smoking. So the point here really is that, in sharing that information, that smoking can literally take away the physical sensations, the pleasures of being human, and can really kill someone slowly. As Dr. Pratima Murthy mentioned, secondhand smoke is a group A carcinogen known to cause cancer in humans. And for every 8 people who die from their own smoking, 1 person dies from secondhand smoke. third-hand smoke is a kind of a newer concept. That's something I always say, the nose knows. When you smell smoke indoors, but no one's smoking around you, it might mean that there's residual secondhand smoke in the walls, carpet, furniture, and there are also some risks tied to that as well, especially to kids. You're closer to those materials, and even pets, which makes me sad. So worldwide, risks associated with the most deaths, tobacco, currently number 2, according to IHME, but I will note that high systolic blood pressure is also associated with smoking, or vice versa. Overall, smoking does reduce life expectancy by 10 years on average. Important for some later slides I'll share. What's kind of important here is that, tobacco is a modifiable risk factor, and what's killing most of us is not infectious disease, and it's really important to recognize in the era of COVID. Granted, we know right now COVID is an extremely pressing issue, but over the long run, we can't lose sight of these modifiable risk factors, including tobacco. And I think alcohol gets a disproportionate amount of attention. Also a very large issue per this slide, but again, tobacco beats that 3- to 4-fold. Let me add one slide here. This is just showing all the deaths attributable to tobacco in the darker shaded colors, sorted by disease. Something I haven't mentioned yet, Alzheimer's disease. That's also a possible outcome from smoking. That's in the bottom left. Something that I think is relatively unique and kind of new in the tobacco control world, looking at the broader societal impact of tobacco. So beyond the individual health risks, healthcare costs we know are exorbitant given the amount of disease and death tied to it. Worker absenteeism, environmental impacts. There's an argument to be made that tobacco production, or cigarette production rather, is a large contributor to climate change. Largely due to deforestation, carbon emissions in production. So beyond sort of the more visible pollution that we see from the trillions of cigarettes that are smoked each year and discarded into our land and oceans. Also an argument to be made about systemic racism and how mentholated cigarettes in the US in particular, and across the world potentially, are exacerbating racial inequity. And human rights, a whole nother topic that I won't go into, but wanted to draw your attention to it because this is such a broad, far-reaching issue. Just briefly, I want to share some behavioral health impact. For this group in particular, I would imagine it's of particular interest. So we know that there's high prevalence of smoking among people with serious mental illness, including schizophrenia and bipolar disorder. Somewhere between 2 to 3 times the regular sort of population's prevalence, but also anyone who just struggles with stress or anxiety, like myself. I know if I ever tried a cigarette, it'd be hard for me to stop. I struggle with anxiety personally. But opioid use disorder, we know that a lot of folks, the vast majority of folks with opioid use disorder in the US smoke cigarettes. And so this is all important context when we're thinking about empathy, as Dr. Pratima Murthy mentioned. We want to avoid the smoker stigma, and we're actually trying to move towards a person-first language approach, calling people who smoke people first, not necessarily smokers. And so my joke on the right here is when you type in smoker on Google, you don't actually see people. You see meat smokers for cooking. So anyway, I think I'm funny, but sometimes it doesn't land. And then just really focusing on the increased attention on nicotine addiction. This is a drug that we're talking about here. I'll run through these slides. I know I'm getting a little short on time. Quitting smoking reduced risks. It's a marathon, not a sprint. It can take 10 or more times to quit to achieve abstinence, at least in the US. Interestingly, most people want to quit, probably because they know about the harms, right? And even a majority try to quit each year, but given how addictive nicotine is, you know, very few, something like 7%, successfully quit in any given year. So more must be done to help them. And then this is a normative question. Who is responsible for smoking cessation? Yes, the individual to some degree, right? But, you know, what role can government play? Quit lines were mentioned in the previous presentation. How can we hold the industry accountable to the death and disease that they sort of impart on society? Medical providers, I think that's kind of where a lot of people land. But in behavioral health, in the field in which you all work, substance use disorder treatment, this is an amazing opportunity. And we know that folks in treatment for substance use disorder who are co-treated for nicotine addiction can actually have outcomes at a population level. They can achieve abstinence. It increases the likelihood of abstinence by up to 25% for all substances. So substance-free means tobacco-free. Briefly, cessation methods and quit rates. I'll just focus on counseling and medication. That's really the key. Very important to pair those two together. Both are more effective together than they are individually. And on the right here, I just show the plasma nicotine concentration, how cigarettes, how the nicotine in the blood system accumulates so quickly within 5 minutes, up to 12 nanograms per milliliter within 5 minutes, comparing to the NRT, the nicotine replacement therapy options. You know, it's just very difficult to mimic. Cigarettes are engineered for addiction. So hence the importance for the behavioral counseling as well. Quickly, conclusions about cessation. It is beneficial at any age, improves health status and enhances quality of life, reduces risk of premature death. It can add up to a decade to life expectancy, reduces risk for many adverse health effects, diagnoses, benefits the health of pregnant women and that of their fetuses and newborns. Very, very important. I'll skip this slide, it was covered before. Just showing some survival curves here. Quitting smoking increases life expectancy. So current smoker here versus never smoked at the top. You'll see that gap here. If someone quits at age 30, they can expect to gain 10 life years. They quit at age 40, 9 life years, statistically speaking. 50, 6 years. So it's never too late to quit. Even if you quit at 60, you can gain 4 years of statistical life. I want to make sure I have enough time. I feel like I'm over time, so I will stop here and just kind of conclude and say this was an amazing opportunity. Thanks for allowing me to speak to you today.
Thank you very much, Nick. Can everyone hear me now? No.
Yes.
You can hear me?
Yeah, we can hear you, John. Thank you.
That's great news. Thank you, Nick. I'm very, very sorry that the beginning there, I lost, well, all of us, all of the staff lost our audio for some reason. So I couldn't actually do a proper introduction for you. And I think it is worth pointing out to all of our listeners your role at the moment, as I know that you gave some information at the beginning, but as a tobacco treatment consultant at Washington State Department of Health, and where you manage the state CDC Prevention and Public Health Fund and the Commercial Tobacco Use and Dependence Treatment Support System grants and tobacco cessation service provision contracts. And, you know, going back to highlight the varied career and the time you have dedicated to tobacco cessation advocacy and improvement of practice and public health at various institutions. Nick has had many accolades and been published for his work. So as you will have seen now that we've heard his presentation, introduction. He's an excellent speaker and expert on the subject. So thank you, Nick. And I'm sorry I didn't get to say that before you actually spoke.
No worries whatsoever.
So now we're moving on to our next speaker. Our next speaker, Dr. Samia Al-Mamari, who is somebody who started out in the nursing profession, becoming director of nursing and working her way through that, including roles as a staff nurse and instructor. And she then changed her work direction to nursing administration and joined the National Rehabilitation Centre in Abu Dhabi as nursing unit manager, and then appointed director of nursing there. In 2017, she was assigned to manage the Director General's Technical Office, and then in 2019 was appointed Acting Medical Services Sector Director, in addition to her responsibilities in the Technical Office. She is chair of ISSUP's UAE National Chapter, so she is a great friend of ISSUP, and is Deputy President of the World Association of Psychiatric Rehabilitation. So, Dr. Samia, thank you very much for joining us. Over to you for your presentation.
Thank you, Joanna, for having me. It's honestly my pleasure to be part of the panels in this webinar. Good morning, good afternoon, good evening, everyone. I know we are talking to different time zones at the moment, so sorry for those who are waking up early, like Nick, to be with us in these presentations. I'm going to present to you part of my study that are currently conducted at NRC about smoking patterns and attitudes of patients receiving treatment for substance use disorders at the National Rehabilitation Center. I'll just go through the outlines. I was going to talk a little bit about the global prevalence. Thank you for my two colleagues. They already covered it in very much of details. I'll take you through later on some UAE situation in regard to smoking. Then we will talk in more details in regard to the study, from the significance of the study, the methods that are used, and also we'll present some of the preliminary results that we had till now. Then we will talk a little bit about the issues of smoking and addiction treatment settings that we are currently facing. And hopefully next time when we meet again, I present to you my final result for this study. As my colleagues before me presented, smoking is really an issue, and it really demonstrates a lot of health consequences for both tobacco users and also non-tobacco users. Both of them suffer from a lot of health-related illnesses. So globally, tobacco kills more than 7 million individuals every year, and more than 6 million of those deaths are a consequence of a direct use of tobacco, whereas around 890,000 are the result of non-smokers exposed to a second-hand smoker. So any type of smoking, any type of tobacco is a form of tobacco can kill or sickness millions of people every year. According to the WHO Global Report on Trends and Prevalence of Tobacco Smoking 2000 to 2025, the prevalence of tobacco, as you can see from the graph, appears to be decreasing in almost all the regions of the world, except within the African and Eastern Mediterranean regions, where it tends to appear to be flattened. And this creates a problem within this region, especially in ages above 18 years old. And the same report, also there was some data presenting the progress toward achieving the 30% reduction in the prevalence of tobacco by 2025. Again, if we look at the table, we can see that there were 21 countries from the Eastern Mediterranean regions. None of these countries, according to the report, are likely to achieve the 30% relative reduction by the year 2025. And there is 2 countries of the same region are likely to experience an increase in the prevalence of smoking tobacco by the year 2025. If we go back to UAE, Again, tobacco smoking contributes to major health issues, as we mentioned, across the globe and also at UAE. According to 2010, the Ministry of Health Prevention report in UAE reported that the prevalence of smoking any tobacco product is 21.6% among men and 1.9% among women. A study conducted by Al-Huqani in 2012 reported that smoking prevalence in males was 24.3%. In females, it was 0.8%. The highest prevalence was reported to be in males aged 20 to 39 years old. The smoker means age was 32.8 plus minus 11.1 years, and most common forms of tobacco in this study was found to be cigarette smoking, followed by midwakh, and also later on water pipe and cigar. These are just, again, some types of forms that are used to smoke tobacco. I think already this was already mentioned in the first presentation. If we go more details in our current study, why we want to study the pattern of smoking tobacco among the clinical population of substance users. Again, global smoking prevalence rates are decreasing. Rates of smoking in the Eastern Mediterranean and Africa region appears to be increasing. There was a recent study conducted at NRC, or the National Rehabilitation Center, revealed that 98% of the participants in this study smoked, and 90% of them started smoking before approaching treatment or even before their addiction. Smoking tobacco product through midwakh is a particular UAE phenomena that has now grown and spread to other countries in the world. So gathering the prevalence rate patterns of midwakh smoking among substance use clinical population should give us some useful information, in particular regarding to if it really acts as a gateway phenomenon for addiction. Shisha smoking is another phenomenon common in this region, and we also will look for gathering more data about shisha smoking among this type of population, or the clinical population, will also give us or add in obtaining a comprehensive picture on the patterns and trends of tobacco smoking in a clinical population of substance users. Would also help us to establish a general picture of smoking in the general population. So information on patterns, attitude, history of smoking in a clinical population of substance users is really valuable at this stage. And looking at all the studies that are conducted here in UAE, there is a very minimum number of studies that connected cigarettes or tobacco smoking to substance use disorders. So we hope this study will give us some information about this topic. The research question is, what is the prevalence, pattern, history, attitudes, and health-related knowledge of tobacco smoking in a population receiving treatment for substance use disorders in the UAE? A potential implication is to establish the size of the problem, collect some information on attitudes and history will give us will be helpful for developing appropriate prevention and treatment intervention and treatment settings for substance use. The study population is going to be both genders, inpatient and outpatient, with different type of admissions, and patients who are going to agree to participate on the study. We thought the sample size is going to be 250. Again, unfortunately, with the COVID situation, we were not able to collect the number that we were expecting during the time that we were having this study last year. So that we're trying to extend it to get at least a good sample so we can present our study at the end. The study design, cross-sectional survey, it was based on the WHO Global Adult Tobacco Survey questionnaire. For those who don't know, the National Rehabilitation Center, National Rehabilitation Center was established on 2002 in Abu Dhabi, United Arab Emirates. It is the National Addiction Response Center mandated for addiction treatment, rehabilitation, research, prevention, human capacity building, policy and legislative development, and advocacy at the same time. Till today, we just collected around 39 questionnaires. Again, because of the COVID situation and also the lockdown, there are a lot of the services for treatment closed down. That's why we did not collect much of samples or participants during these previous months. So the preliminary result, till now, we have 80% response rate. There were 23 males compared to 8 females were already involved in the study. The age range between 22 years old and 38 years old. With a quick analysis of their current tobacco use, 75% of them reported that they are using tobacco on a daily basis. The age of daily smoking, one of the questions was about when was the first age, when you were the first time you started having a daily smoking pattern. A lot of them reported that they started at the age of 13, and it ranged between 13 and 30 years old. The products that most of our the participants smoked were cigarettes, 58%, midwah, 48%, and shisha, 25%. What are some of the issues that we face within addiction treatment setting in regard to smoking? First of all, it's an area that's none of the staff will address. So it's seen as no-go area by staff. A lot of the treatment settings thinks that or assume that having tobacco smoking available within the premises will help their decrease the stress of being in a treatment setting. Making treatment available, having all type of treatment or smoking cessation treatment available within the treatment center itself also is an issue here in the UAE. Training the staff on how to introduce smoking cessation treatments or also introducing the topic of when to stop smoking with patients is another area that we face some of the issues with it and require a lot of training and improvement among the capacity building of staff. Even after the training, even after making the treatment available, there is another problem regarding to making sure that the staff bring up the subject of smoking and using motivational interview techniques during the discussion with the patients in their treatment setting to help them quit smoking. These are just some of the issues that we face currently within any addiction treatment settings. At the end, even though tobacco smoking prevalence in the UAE is less than any or many other Middle Eastern countries, it is a prevalent habit among young individuals and can lead to the rise in smoking associated comorbidities. This is in general, but if we connect this to addiction, and we still have that question that we hope by the end of this study we can have a simple answer for, is smoking tobacco is a gateway for addiction. Thank you so much.
Thank you very much, Dr. Samia. We appreciate you giving us a sort of more localized, we've had the broad picture, but it's great to hear then a more localized study, and good luck with the work as it continues. We're moving on now to our last speaker, Dr. Adam Kulhanek. He is a tobacco dependence expert at the Department of Addictology in the Faculty of Medicine and General Hospital at Charles University in Prague in the Czech Republic. And within that, his roles include taking on the head of the Center for Tobacco Use Prevention and Research, He's a clinician at an inpatient detoxification unit, as well as a child and adolescent detoxification unit. He's a researcher, he lectures and supervises the students as well. Away from that, he is also a tobacco dependence specialist with the National Tobacco Quit Line in the Czech Republic and vice president of the Czech Coalition Against Tobacco in Prague. And if he has any spare time, a senior primary prevention worker for the Jaws and Gym initiative. So thank you very much, Dr. Kulinek, for joining us today. We look forward to hearing your presentation.
Thank you, and hello everyone. And I would like to briefly present our experience from clinical practice, from our department, and the through line of my today's talk is a question if we are able to manage a smoke-free detoxification unit. And my answer for this question is yes, we can. And I would like to present and share with you our experience with implementation of fully smoke-free detoxification unit for patients undergoing addiction treatment. First of all, I would like to disclose that I have no conflict of interest. And let's move on. First topic of my speech. As previous speakers say, tobacco smoking is quite serious problem, and when we compare general population with patients with substance disorder problems, then prevalence is more than 4 times higher than in general public. So it's quite big problem when our patients are tobacco smoking together with using other psychoactive substance. And there are also a couple of myths which create barriers when clinicians try to implement fully smoke-free departments. But when we compare the myths and the benefits, or the risks and the benefits of concurrent tobacco cessation, smoking cessation, and treatment of primary addiction, the benefits are more significant. As you can see here at this slide, we can, for example, reduce significantly premature death. We can improve health of our patients. We can improve the recovery process in terms of treatment of primary addiction. In long term, there is a stabilization of psychiatric symptoms when patient undergoing addiction treatment stop smoking successfully. And last but not least, based on research, stopping smoking can increase addiction treatment efficacy. And one of some significant benefit for patients who stop smoking is saving a money. This is Dr. Scala, and this is founder of our institution, of our department. And let's have a look to this number, 1948. In this year, our department was established. So there are quite deep history behind our unit and our department. And Dr. Scala was psychiatrist and kind of good father of addiction treatment in the Czech Republic, in my country, in Central Europe. And he was also a smoker, and he tried to quit and quit successfully. And he had one wish to implement and to start a smoke-free institution. And he tried to implement a smoke-free department 2 times in his career. Try to guess if he was or was not successful in this case. Unfortunately not. His attempt to quit smoking was successful, but his attempt to start smoke-free institution was not successful. And why? Due to a lot of myths about concurrent smoking cessation and treatment of addiction, and due to smoking, who mostly due to staff who mostly were smokers. Let's move on to 2019 and the third attempt to establish a smoke-free ward. In this year, we started to prepare a novel conception of detoxification unit and to implement a new conception. At this point, I would like to briefly describe our detoxification unit. It is operated as a separate unit of Department of Addictology. It is indicated for adult patients and provided as a co-educational department where is women and men together. And most of our patients are alcohol users, illicit drugs or prescription medication users, and few of them are also pathological gamblers. We have there 12 beds, and hospitalization lasts between 7 to 30 days, according to health and psychiatric status of the patient. And what is not shocking, that about 90% of our patients are also tobacco users. But as I mentioned, our department was not originally non-smoking. It was unfortunately smoking detox. So let's have a look to the older detoxification unit. We have had there kind of smoking breaks, and our patients could have 3 cigarettes per day after breakfast, after lunch, and after dinner. And in these smoking breaks, nurses went with the patients in front of the hospital to the garden, and then patients could have a cigarette. But in 2019, we tried to change this conception from the scratch. And we started to prepare a methodology and instructions for the staff. Then we provide a staff training and then continue with pilot implementation. Now I will show you the process step by step and share with you our experience from clinical practice. The main condition for every patient who is admitted to the ward is that the patient cannot use any type of tobacco or nicotine products. It means cigarettes, e-cigarettes, heated tobacco, nicotine pouches, etc. So no tobacco, no nicotine during the hospitalization. When we thought about support of being smoke-free for a couple of days when our patients are hospitalized, we call it a 3-pillar system, and we use nicotine replacement therapy ad libitum and for free. Then we provide group counseling, closely focused on smoking cessation topics, and also we provide individual counseling to patients who are tobacco smokers. When we start with diagnostics, we use these 2 questionnaires. Fagerström test for nicotine dependence we use to measure physical nicotine dependence, and in case of admission of patient, then my colleague, psychiatrist, administered the questionnaire with patient, and then we use Minnesota Tobacco Withdrawal Scale to measure improvement of withdrawal symptoms during the hospitalization. Some information about nicotine replacement, how to deal with. We prefer nicotine patches, mostly the strongest dosage, 25 or 21 milligrams, because it provides a stable saturation during the whole day, and nicotine replacement are indicated by medical doctor during the admission, and patients can use it ad libitum and for free during whole hospitalization process. Group counseling or groups for tobacco smokers are organized one week, and it takes 60 minutes. We have there between 5 and 7 people, 5 and 7 patients, tobacco smokers, and are provided by addiction treatment specialists. And in many cases, most cases, by myself. Individual counseling is provided as on-demand support for patients who would like to continue with smoking cessation in another treatment of their primary addiction, and these are organized once or twice a week and takes about 45 minutes. When we started to prepare the smoke-free conception, smoke-free unit, we were afraid of a couple of topics and a couple of kind of barriers or myths related to this process, to this changes. So let's briefly discuss these fears, these topics. The first one was decompensation of patients, especially in case of patients with some psychiatric comorbidities. Fortunately, it didn't happen in most cases. And why? The reason is that we use, as I mentioned, the nicotine replacement transdermal patches with the highest dosage of nicotine. So therefore, then patients are stably saturated and do not suffer from withdrawal symptoms, and there are not disbalances in moods and psychiatric symptoms, and also psychiatrists observe the patients quite strictly during the treatment. So this is some experience how we deal with this problem, this topic. The next one was that we were afraid of decrease of treatment inquiry. In other words, less of patients, and fortunately it didn't happen as well. And why? Because we trained our staff how to communicate with patients by phone before admission, and how to positively motivate them, and how to offer them the benefits of being smoke-free for a couple of days. And every nurse, when calling with the patient before the treatment, before the hospitalization, inform them about using nicotine replacements, about the availability ad libitum and for free, about the support. So it really works and in clinical practice. Next topic, or next fear, next issue was the increase of dropouts. And fortunately, there were really very few dropouts of patients in the first year of smoke-free detoxification unit. From 180 patients in 1 year, only 3 leave the hospitalization due to the condition that they couldn't have cigarettes in detoxification. And last but not least, non-cooperating staff, which in mostly cases are quite huge barrier in this process. In our case, we have there mostly non-smokers, and in our team are only 2 former smokers, nurses who switched to the electronic cigarettes, and currently they use electronic cigarettes. So the condition to have a non-smoking staff is a very good prevention to cooperate better in the team. Also, we discussed the topic and the changes and the spheres in supervision sessions with external supervisor, and also we trained our staff in interventions and educate them how can react, how they can provide brief interventions, motivational interventions, etc., etc. So thanks to this combination, they works really well. Maybe you are interested in some data, some results. We have a lot of data, we have transcribed it, but currently we we provide some statistical analysis, so I cannot right now present any results of the first period of pilot implementation, but we have there some paper just in Czech language, and there is a written the process of implementation and each clinical steps of providing smoking cessation and support during hospitalization. And I hope that soon we will publish some paper in English with results, with data, with outcomes of the implementation. To conclude, I would like to say that we can manage smoke-free detoxification units. Thank you very much.
Thank you very much. That was an excellent presentation, taking us into, the dynamics in your hospital and your experience. We look forward to sharing that paper with our members, and hopefully, the English version as well as the Czech. So thank you. We have time for some questions, and thank you to all of our listeners for submitting those. We had many questions, so I'm afraid I've had to sort of select which subjects the questions came in around the most and cherry pick a few. Our first question is to Dr. Pratima. Given the amount of evidence against smoking and the benefits that we know about, all the health benefits and all the harms associated, etc., why is it that so many continue to choose to smoke, or is choose the wrong word? And our question giver says that they know that the excellent speakers have offered answers to this question, but yet people still smoke and stop smoking. Can you give us any insight into why, and if there's anything we can be doing?
I think the simplest question is because it's addictive. And therefore, when people start using tobacco, they don't understand that, they think that they have full control over what's going to happen. They can regulate the amount they take and, the quantity they take. But over time, what happens is that the person develops tolerance to the effects, and therefore, needs to increase the amount, and then a loss of control and the inability to, control the use of the drug. And that's why a lot of people, and I think Nick mentioned that 70 to 80% of people want to give up each year, but actually only 1 to 2% are able to by themselves. And that's why it's so important to provide them support to be able to quit.
That's very useful, thank you. Could you talk a little bit about the sort of initial use, when we're going back to when we're sort of thinking of our prevention listeners, and that sort of initiation with that question, what is the motivation, some of the incentives for people to have that initial use, and what can we do to prevent that?
Okay, so I think there is this public perception of tobacco being something that's normally done, that it might actually, improve a person's mood, help them to relax and so on. So I think somewhere in society, and I think it's already beginning to happen in many countries, that you denormalize the use of tobacco. Because otherwise, the positive expectancies around tobacco, that generally, what people think is that it relieves boredom, it, makes you feel good, it helps you unwind, it helps you de-stress, etc. So I think it's about telling people that these are very temporary effects and that they actually lead to much more harm than good. Number one. The second thing I think is, as a society, we need to learn ways of unwinding, safer ways of relaxing, safer ways of having a good time, and that's, I think, is very, very important from a preventive point of view.
No, yeah, it's a sort of a broader approach. It's very interesting. Thank you. Now we've got a question for Nick. If tobacco is so dangerous and harmful to even people who don't deliberately smoke, why is tobacco smoking not banned or prohibited?
Question I have been wondering for a long time, and I assume you can hear me?
Yeah.
Okay, speaking just in terms of the US, we are very conscious of our freedoms and individual rights, for better or worse. Even though there is no constitutional right to smoke, tobacco is really ingrained in our nation's history. And I'd go so far as to say that commercialization and sales of tobacco is one of the greatest mistakes in our history. So to really kind of answer the question, I think there's some resistance here. Prohibition of alcohol didn't work. The fear of a black market showing up, you know, illegal sales and all the ramifications that come with that. I will say that there are tobacco endgame strategies. Tobacco endgame, if you Google that, such as prohibiting tobacco sales to people born after a certain year, some countries are looking at those options. And there are actually 2 cities in California that have banned tobacco sales. So we are getting there. We're probably a few decades along, but it has to be kind of this chip away approach, because there is so much, sadly, so much money to be made in a very strong tobacco industry lobby. That's my answer.
Thank you very much. Thank you for taking that one on for us. Now we have a question for Dr. Samia. If you are still able to respond. We had a question which came in about accessibility and how that provides a challenge for people quitting or for cessation initiatives, and what tools the cessation initiatives have to take or strands to those approaches to deal with how accessible tobacco products are to the people that want to quit.
Okay, if I answer the question more related to the UAE, there are a lot of regulation being put through to stop smoke or to reduce the smoking among the population. There are certain age that are not allowed to buy. There are certain places are assigned to be for tobacco sale. So there are a lot of regulation being conducted and policies being changed and modified to start reducing it. But again, as Nick was saying, there are a lot of things involved in smoking that prevent it from or prevent the communities or the governments from really trying to reduce it. If we talk in particular regarding to addiction treatment centers and the smoking cessation programs within these centers, if we talk about us here at the National Rehabilitation Center, we do provide our patients with tobacco cessation treatments as an option for them on admission. The female unit, for example, is tobacco free. So we don't have any smoking within the female units, for example. We provide a lot of alternatives. Again, it's a patient choice that we cannot honestly influence much. We try to educate them. We try to motivate them to quit and stop smoking, but we still continue to do that. And hopefully we reach that point where we reduce the number of smokers in the community.
Thank you very much, Samia. We have a question for Dr. Kulanek that we were asked about how detoxification approaches or effectivity is affected by the age of the people that smoke. So could you talk to us about that as a factor within approaches and within the results of those approaches, please?
Thank you for the question. I'm not sure if you mean the history of smoking or the age of the patient.
The age of the patient, so you know how that affects how you differ your initiatives based on the age of the patient, and you know what the results of different types of detoxification, or you know that you talked us through the different approaches and how age of the smoker affects the effectivity of those.
Oh yeah, thank you. In case of younger smokers, we have the experience that the detoxification is quite smoother and faster because of the health status of the organism, the body of the smoker, of the patient. In case of older smokers or older patients with the longest history of addiction, for example, alcohol use and drug use, then it is quite more complicated, and we have to use more medication, more psychiatric medication, and higher doses of nicotine, for example, combination of 2 nicotine patches. So yeah, younger patients with less cigarettes per day and a shorter period of their addiction benefits faster from the detoxification and spend less days at our department than other patients with a longer history of addiction and smoking.
Okay, thank you. And just one last question, and I will allow our panel to choose, volunteer if you would like to answer it. But a lot of people have asked about the impact of COVID and whether the numbers have increased, how people are having to deal with dealing with it differently. So if any of you could just give us a little bit of a picture about this specifically during COVID.
Let me start answering that question, Joanna. I think we run the quit line. We run the quit line, the regional quit line for Southern India. So one of the things that we have realized is that the number of people who call the quit line with an interest to quit has actually increased. And their commitment to quitting is also increased. So I think that's very, very important. And in some ways, I think the COVID, if one can say that there is any kind of, not a silver lining, a slight silver lining, is that I think a lot of people with tobacco use are realizing that it's very, very important for them to stop. And therefore, I think that's something, and I think we see COVID as an opportunity to tell people to quit smoking so that their risks and their recoveries from COVID actually reduces. But on the other hand, we do know that, people who are staying home, people who have nothing else to do, people who are bored, the risks to tobacco use, and increased use is also higher. So I think one needs to look at it from both perspectives. The fact that, lockdown and working from home, etc., the stress of COVID has increased tobacco use, but at the same time, I think spreading the awareness about the risks and the opportunities to quit, and most importantly, providing support for people to quit is very, very critical at this time. So that's my take on it. Thank you.
Thank you, Dr. Murthy. Nick, did you have a response to that as well?
I'm just fascinated. Quitline calls in the US have gone down dramatically during COVID. So we've had the opposite effect. So it's super interesting, and we should compare notes or something and figure out how to increase our calls to the quitline, because I think stress and anxiety have increased and smoking has increased. Or not positive about that, but it sounds like this may be our first year where we don't see a decrease in the smoking prevalence. But we'll know soon enough. But thanks for that.
Nick, may I just make a correction that the number of calls to the quit line have reduced. The number of people committed to quit with an interest to quit has increased. The relative numbers have increased. I just wanted to clarify that.
Okay, interesting. We should definitely talk though.
Thank you. Any perspectives from UAE or Czech Republic on that? Okay. Well, oh, sorry.
Okay. Honestly, I'm not aware of any statistics in regard to specific smoking or quitting smoking within the UAE. But if we look to the whole scenario of the pandemic itself, and we combine it with an existing addiction, so people are already smokers and they've been put in quarantine or in a lockdown with the anxiety and the depression that this situation will develop. I think this all will increase that, and the tendency to be more smoking heavily more, or even to use it as a coping mechanism for the situation that are put in. So I think hypothetically we could say it's increased. Okay, currently I don't have the statistics that support it, but if we put it all together, it tends to be an increase during the pandemics or especially COVID situation.
Thank you. So that is it. I'm sorry for those of you that asked questions and we didn't have time to get to them. We had a great number of questions and great interest in this subject. So I want to thank our speakers again. It was an excellent panel, really great presentations, and we thank you for sort of introducing this subject and then going into the details that you did from your different perspectives. And thank you to ISSUP India for pulling this panel together and this webinar. And again, we're wishing everybody there the best in dealing with the situation with COVID at the moment. Thank you for listening. We appreciate you joining us this afternoon. The presentations, we will ask our speakers and make those available where we can on the ISSUP website. And as I said at the beginning, the recording of this webinar will go also live within the next couple of days. So unless I have missed anything from my colleagues, I will just remind you that there are 2 more webinars in this series, so we hope that you can join us on those next 2, and we will look forward to seeing you then. Thank you.